Okay, sir.
Ah,
Now you can start, sir.
start. Okay. So today we will start the osteotomy lecture, osteotomy around the hip. Actually, we have to now start on online on our lecture series. Can you hear me?
Yes, sir.
Okay, go ahead. Okay. So what is osteotomy? Osteotomy is a surgical correction procedure used to obtain correct biomechanical alignment of the extremity so as to achieve equivocal load transmission performed with or without taking out the bone. Osteotomy does not mean you have to take out a bone. It can be just a corrective osteotomy. It can be open wedge. It can be closed wedge. So it is not necessary we need to take out a bone. Sometimes we just do a displacement like a McMurray. That is the main definition of osteotomy. So it gives mechanical, biomechanical alignment of the extremity so as to distribution on the hip joint can be started. That is the main principle of this osteotomy. Going back to the history, just only few slides because we don't want to bore because this is not very important, but we have to know our ancestors. So the femoral osteotomy first was John Ray Barton. He did in 1826 for a tubercle hip. He was an American surgeon. He just did a corrective osteotomy. That is the time the osteotomy started in the orthopedics. Lawrence, he did a upper femoral osteotomy. This was called osteotomy was called as a bifurcation osteotomy actually, upper femoral. Look at this, it's like a Y, it's like a V, or something. This was done for a very high dislocated hips. Then the stance osteotomy was most popular in 1934. This was a German surgeon who did osteotomy at the level of the ischial tuberosity for old dislocated. At the time, a lot of dislocated hips were there because there was no protocol of a CDH. So a lot of osteotomies were done around the hip at that time. And the stance osteotomy was very popular. It was a stabilizing osteotomy called as a pelvic support osteotomy. This was. Still, many people do this osteotomy with slight modification, especially old excised hip, tubercle hips, hips. So make the stability, and then they do a lengthening, which I'm going to show you one or two cases. The McMurray osteotomy was very, very popular. In 1936. He was a professor at the Liverpool University, McMurray osteotomy. And my chief, that is Dr. Professor Dholakia, I did know a couple of stories of McMurray. He was a very good surgeon, a very skilled surgeon, very, very skilled surgeon, and a lot of record he used to keep at that time. And every Sunday, he used to take all MCH boys on either a tour or sometimes he used to take on he had a small boat, I think yacht or something. He used to take them along with that, and they will have a small party. So that was McMurray, TP McMurray. I'm going to show you one or two osteotomies of this also, gentleman. So some clinical, before any osteotomy, we need to have some clinical assessment of patients before the osteotomy. So there are varieties of osteotomy require a prerequisite. So we need to know a couple of the things I'm not going to the detail of the clinical examination. That is itself is a different topic itself. So we need to know tender limb or a sign. What about genu, varum, valgus? If you do too much of abduction osteotomy, if the knee is already in the valgus, you will land in the excessive valgus. So we need to know what is the knee alignment. Actually, we have to know what is knee alignment, what is spine alignment. So the joint above and joint below. Hip joint contractures. What about the contractures? What about the mobility at the hip? What about the pelvic tilt, lumbar lordosis or kyphosis? So we used to know there's a fixed pelvic obliquity or a mobile pelvic obliquity. Fixed pelvic obliquity is a big problem because you will not be able to correct the pelvis. Range of motion we have to see. Active, passive, many fixed deformities are there. What about the limb length? That is another very important because most of these osteotomies we are doing for young people. So we need to know what is the true limb length of these patients because most of the time we will not be able to give a limb length to them, most of the time limb length. So it is very important to discuss with the patient also. What about the radiology? Today we don't go too much of this because of the CT scan and MRI, but still there are certain basic requirement of the hip X-ray. Today we are doing more and more now standing X-ray because that's called dynamic X-ray. Dynamic X-ray. So we need an AP upper third with both hips. True lateral view sometimes. Sometimes we do a frog lateral. That's called as a dysplastic view. That is, we do it in a standing radiograph in a standing radiograph. Sometimes with a dysplasia, we want to know whether the hip is getting reduced or not. So we do what is called an abduction X-ray, internal rotation, whether to know there is a containment or not. For osteonecrosis, there is called as a spatial localized necrotic segment. Today we don't do these views. These are absolute now. So today we rely on MRI and the sector involved. So these are osteotomies which required for a very early stage 1, stage 2. Some of the osteotomies are required so as to know what amount of segment of the hip is involved. So X-ray does not give a good picture. It has to be on either, most of the time now it is MRI is a more gold standard now rather than a CT scan. So how do we classify these osteotomies are? Osteotomies around the hips are we will discuss with classification, little bit of biomechanics. We'll cover acetabulum and proximal femur, whether it's possible both or not. I don't know because it's a too lengthy lecture. Let us see how it goes. So the classification there depend on 3 now. How is the displacement of the distal fragment? We don't consider proximal fragment. Osteotomy displacement. We classify according to the distal fragment displacement. Second, anatomical location, whether it is a peri-acetabulum osteotomy, whether it's transcervical, intertrochanteric. So we go on anatomical location. And third is based on indication, whether you are operating for containment, whether you are doing for a fracture union, or whether you are doing for stability. So we'll go one by one in these 3 types of osteotomies. So first is the displacement of the distal fragment. So there are different types of osteotomies for the displacement of the distal fragment. First is called transposition. So you cut it and underneath the position wherever you want. You are not going to take out any wedge. You are not going to do anything. It is only a transpositional osteotomy. McMurray was intertrochanteric oblique transposition osteotomy. So that is a McMurray osteotomy. Second is angular osteotomy. Whether you are going to do sagittal plane or coronal or whether it is triplane. What is about the sagittal plane? That is in anterior posterior. Whenever there is a flexion deformity, we will do extension osteotomy. So that is in sagittal plane. Second is coronal. That is on mediolateral. Whether you are going to do abduction osteotomy or adduction osteotomy. Abduction osteotomy is usually valgus osteotomy and adduction osteotomy is varus osteotomy. So according to the transposition, according to the angular osteotomies. Then what about the anatomical? Second part, that about now I talked on and transposition. Second is called as anatomical location. Whether it is high cervical, intertrochanteric, subtrochanteric or greater trochanteric. These will be on the mainly on the femoral side, not on the acetabular side. What about based on indication? These are a little lengthy, but there are based on indication. That is very important for us because we are going to operate for indications most of the time. So we do an indication to achieve stability. Most of the time, there are unstable hips. Either they are dislocated or they are excised hips, unstable. I just told you Lorentz bifurcation, Shanks osteotomy, Hayes osteotomy. One by one, we will show you examples also. Second, not for stability. Second, to achieve compression force for union. In olden time, non-union rate was very high. So we used to do varieties of osteotomies. So McMurray was one of the Dixon, geometric, Powell osteotomy. Putty is now we don't do any putty, but Powell is very powerful osteotomy for especially for non-union, which one example I'll show you. McMurray definitely it was. We'll go to the principles of McMurray when we discuss on the McMurray. So to achieve compression for union, the second based indication. Third is relief of osteoarthritis. So Powell 1, Powell 2, they're varus and valgus. McMurray also in the olden time was done for osteoarthritic patients. because of the principles we will discuss. So these are some of the osteotomies to relieve pain. Fourth is to correct unstable fracture. That is like a diamond Houston and sermento that we don't do today. So that is out of question now. Today we do not do this. The complication rates are very, very high. Then to correct deformities, that is very important. Coxa vara, slip capital epiphysis. We do varieties of osteotomy like intracapsular cuneiform osteotomy, Powell osteotomy, Langenskill osteotomy. These are the osteotomies done for correction of deformity, whether they are coxa vara, whether they are flexion deformity, whether adduction deformity. Varieties of this can be done. For avian, Suzuka transtrochanteric osteotomy, which is now not done. Suzuka only had the best result. Most of the world has left this osteotomy, but still we do have something called varus derotation or some amount of rotation osteotomy for something like what is called as a small segment, 10 to 15% of the hip and head involved. Then only this osteotomy work. Large segment, this osteotomy does not work. Still, people do varus osteotomy for avian in younger patients. Then we do for paralytic dislocations like varus derotation or extension. Polio, especially extension osteotomy, was very common for unstable hips. So that is one for paralytic, for avian, correction deformities. So let us discuss something on this biomechanical principle. This is very important slide. We will take some time in this discussion. I need to see where is the we don't have. Okay, my pointer is there. Okay, are you able to see the pointer?
Yes, sir.
Yes, sir.
Okay. Now, in a biomechanics of the hip, there are two arms. One is known as an abductor arm. Second is known as a body lever arm. From the center of the head to the pubic symphysis is known as the body lever arm, and the center of the head and the tangent passing from the trochanter as an abductor line of abduction called OB is called as an abductor lever arm. So this is the body lever arm, this is an abductor lever arm, and this is the center of gravity going through. So this is normal center of gravity to the pubic symphysis. But it doesn't go normal when we walk. It doesn't go into the pubic symphysis. It goes on slightly opposite side. It oscillates, depends on the stance phase and the swing phase. It doesn't go right in the center. It oscillates a mediolateral and anterior-posterior both ways. But most is in the mediolateral plane rather than anterior-posterior plane. So it moves. So this arm, if you look at the S, this is S1. And the K is an eccentric force on the, when we stand on this, the body, this arm moves, the K moves towards the opposite side. So K is an eccentric force on the hip joint. That is very important. K is an eccentric force. Now, for this eccentric force, the abductor lever arm has to do equilibrium. So this is called M. M is nothing but the equilibrium maintained between the body lever arm and this magnitude of abductor. Now there is a result between these two. There is a resultant force, and that is called as R. So again, K is the eccentric force on the hip joint. M is the equilibrium created by abductor lever arm, and R is the real resultant force on the hip joint. Normally, it can be 3 to 4 times the body weight because the abductor arm is a very short and a body lever arm is very long. So the abductor has to work 3 to 4 times than the body to maintain the equilibrium, which will come to again with some descriptive figures. So do you get my point now here?
Yes, sir.
Yes, sir.
Okay. This is a very important because everything now is going to depend on quite a bit of is going to depend on this principle. So body lever arm, abductor lever arm, resultant force, and the K moves. It doesn't move in the center. Okay.
Yes,
So
sir.
the line of action of K oscillate backward, forward, I told you, in the sagittal plane, and to some degree remains close to coronal plane. So it is not a stationary, it moves. And magnitude R depends on the distance between the body and the abductor lever arm, which I told you, either 3 to 4 times body weight, etc. 1 minute, I will just close this. Because I'll call you on webinar. Sorry. Now,
Yes.
if you look this is a very important thing. This is your body lever arm. This is your abductor. So this is no equilibrium there. So this is very close, and this, look at this amount of weight it has put on this side and weight on this side. So this has to maintain that body lever arm my abductor lever has to maintain that body lever arm. So this is the main principle. Actually, Chanley also was able to adopt what he did in Chanley, because he wanted to reduce the resultant force on the acetabulum. So what he did, he medialized the cup. So he reduced the body lever arm by about 4 or 5 millimeters, and he wanted to increase the abductor arm by detaching the trochanter and distalizing the trochanter. So he wanted to lateralize the trochanter to increase the abductor lever arm so that some part of the equilibrium can be done so as to reduce the weight on the resultant force on the acetabulum. So that was a principle of Chanley. But what happened? He lost a medial wall on the acetabular side, and he started loosening. So that is the reason he left. He did not do the medialization afterwards. But he continued his lateralization of the trochanter, because he did all his transtrochanteric by doing lateralization. But many people today do not do lateralization of the trochanter, but we will try to maintain the various offset and increase the abductor lever arm, and that's the principle we still follow. So trying to maintain the equilibrium between the body lever arm and abductor lever arm, that is the main principle to reduce the resultant force on the acetabulum. That is a basic principle in this. Now, another important thing, on limping on the same side, the patient, they do a limp on the same side of the body to mask the K come closer to the joint, leading the reduction and amplitude finally. Now what happens when they limp on the same side? What happens? The K moves towards that side. So the body lever arm gets reduction and abductor lever arm remains the same. So your body, as you limp on the same side, the body lever arm gets reduced and automatically the resultant force is reduced. Do you understand?
Yes, sir.
So that is important. That's why the most patient will limp on the same side on the difficult side, that is the arthritic side, so as to reduce the body lever arm.
Yes, sir.
So if you use a stick on the contralateral, so the magnitude is quite get reduced magnitude, and that's why you will have reduction in the resultant force, because something like 11 to 14 kgs of the weight will be passing through that through the stick area. So this will reduce automatically. It will reduce this. But if you use a cane, on ipsilateral same side, the body weight passes directly through the cane and it will not change much. So it's very important to use on contralateral side. So this also figure shows that if you look at this, look at that. So instead of going S1 here, so this has completely changed. It has come towards the hip, the affected hip. So this part of the body lever arm has reduced, and the cane takes almost about 11 to 12 kgs on that side, and it will reduce the amount of forces this. So cane and limp both decrease the forces exerted by the body weight on the loaded hip. Cane transfers the part of the body weight to the ground, thereby decreasing the muscular forces required for balancing. Limping shortens, that I told you, limping shortens the body lever arm. So you have to, you have to remember how it is shortened. This is what is again described here by using a cane. And that's why we do prescribe elderly patient, the cane is very important. You realize on this how cane important, but most people, they are shy to use the cane. That is the biggest problem in this country. But most of the Western country people, if you look at them, they will have, a lot of patients will have a cane in the hand. So with this biomechanics, how do you know the hip is taking good amount of weight? It's a very, very important, which has been described by Bombelli, an Italian surgeon who wrote a book on the osteotomy also. I had opportunity to assist him and had a lot of discussion. He came thrice to India. He did a couple of osteotomies also in India when I was at Bombay Hospital. Anyhow, so I will just show you, very important he described. There is called I will describe what is normal sursil, normal uniform sursil. I will go to the next figure and come back, then you will realize. If you look at them very carefully, can you see this area of a sclerosis? That is called sursil. Sursil is nothing but eyebrow in English. Okay, that is Italian word sursil. Okay, so if the normal hip stresses, you have a normal eyebrow. Okay, the hip has now started subluxating partly, and if you look at the medial joint space has increased, and sursil has started become little more thicker and triangular type, oblique type. It is nothing like eyebrow now. It is little broadened. That means weight is more transmitting on the little more laterally. That is the second type of sursil. Third is now complete getting subluxation, so you get a triangular sursil. So on sursil, you know the hip is normal weight bearing, normal stresses are passing through or not. Very important figure. If you retrospectively go and see all x-rays, you will realize this, otherwise you will not realize. Now, there is a protrusio. Instead of having a normal sursil, now that sursil has become completely throughout the acetabulum. That means hip is loading much more on the medial side. That happens in protrusio. So I go back to my original slide. So normal uniform thickness is sursil. Cup-shaped substance is the first sign of primary OA. Triangular is subluxation, and triangular on the medial side is a protrusio. Is it clear to all of you?
Yes, sir.
Yes, sir.
This is very, very important in day-to-day. The meeting has upgraded. The host includes the limited minutes. Okay.
No, that's fine, sir. That's fine.
Let us go to the next slide. Is it clear to you, all of you?
Yes, sir.
Yes, sir.
Because this will work beautifully. So now look at this one of the example of protrusio. Look at this. The whole thing has gone medially, joint reduction. This is a complete sclerosis, much more on the medial side and the medial osteophyte formation. That itself indicates it is getting protrusio. Now, very important figure. These are very practical. If you look at this slide, can you see this second important part we look at is what is called as a teardrop. We talked on sursil. Second is teardrop. Normal teardrop. Let me go back. Oh, yeah, it's not there. We will go back. We will go to the second slide. Normal teardrop. This is not a normal teardrop. Can you see this? It is a wide. Can you see on the opposite side? Opposite side? That is the teardrop. Both lines are hardly you are able to see that, very, very minimal you will be able to see. If you see a widening of the teardrop, that means this hip is not loading enough. Clear to you?
Yes, sir.
Yes, sir.
Yes. See, the lateral view also shows here. Okay. Now, second type The hip is not inside at all. So teardrop is not going to develop. So it is a quadrilateral teardrop. Can you see this teardrop?
Yes, sir.
And the margin of this teardrop is also very faint. They are not sclerotic. So this is a Wolff's law. When the stresses are passed, new bone is formed. So if the stresses are not formed, teardrop does not get formed. Crystal clear?
Yes, sir.
After full seal, the next important is the teardrop. So we know on these two basics how the hip is getting transmitted weight, how the hip is loading. That is important. So there are 3 to 4 types of teardrop. These are two or three other I have shown you. So let us go to the now a couple of osteotomy which are important, which are for the exams are important, and the surgeons are going to ask you a few basic principles. You may not go into the depth of it, but very important to know a couple of osteotomies. And the first osteotomy, we will discuss osteotomy of acetabulum, then we'll do on the femur side. Salter osteotomy. This is an innominate osteotomy. This gentleman described in 1961. He is from Toronto General Sick Children Hospital, Robert Salter. I had opportunity to assist him in Mumbai. He did 2 CDH operations in Mumbai because, you know, my boss was very, very popular. He could bring anyone out from outside, and we learned the CDH osteotomy from this gentleman, Robert Salter. So what is this osteotomy? This should not be done under the age of 18 months. It has to be 18 months to 6 years. And after 6, you can't do it. We will come to that. Why? Second, the hip should be reducible. It is subluxated, but abduction, internal rotation, it should be able to contain it. If it doesn't contain, then you require open reduction and Salter. It is possible to do it. Both together, it is possible to do it. It is not necessary that it has to be reduction. Very important. Third important point, the acetabular correction index, what you call as a acetabular index correction, it cannot be achieved more than 10 to 15 degrees because it is a redirectional osteotomy. Acetabular configuration does not change. We'll come to. The entire acetabulum with pubis and ischium rotates on the symphysis. So where is the hinge? Hinge is very far away. It is not very close. And that's why we do not get that fantastic correction. We get a very small correction of 10 to 15 degrees. And it is another important thing. Roof is shifted anterior and lateral. That's why this osteotomy cannot be done in paralytic dislocations because it does not cover the posterior part and the medial part. So it is very important that the roof is shifted anterior and lateral. So that is the only cover you are going to get achieve. So age is a limit. Reducible, it is better. We cannot do a correction more than 10 to 15 degrees of acetabular index. Whole entire acetabulum moves on the and the symphysis is a hinge which is far away, and that's why correction is very minimal with this osteotomy. Roof is shifted anterior and lateral. This is going to be, people are going to ask in exam. So it is a greater simplicity operation. No change of acetabular the configuration does not change. It is only redirection or reorientation osteotomy. Can be done in older children only for lengthening, but we do not do for this osteotomy anymore. So it should be under the age of 6 years. Disadvantage, it is unstable. It requires fixation, pins. It will require removal of wires. It is less versatile because it gets only one correction of acetabular index, 10 to 15 degrees, and anterolateral. You can't redirect wherever you want. So it is has got limited role. It is a less versatile. Posterior part is uncovered. That's why I told you. This cannot be done for paralytic dislocation. So posterior part is uncovered. So you look at this, what is called redirection osteotomy. So this is the, what you see is this head like this, hat, cap. So only this cap has changed its direction. The configuration of the cap has not changed. Okay, that is a read. That's why it is called redirectional osteotomy. So what we do in this osteotomy is we do a anterior Smith-Peterson approach, and this osteotomy is done as the anterior inferior iliac spine. Anterior inferior, that is the level of the osteotomy. We do it anterior inferior iliac spine. So that is the area where we do anterior inferior iliac spine. We open that, we bring the distal fragment anterior, lateral, then we took a small wedge of bone from here, and that open, whatever the wedge is open, we put that wedge. One trick in this, sometimes the osteotomy does not open. What you should do in a slightly older children, take the hip, operated hip in abduction, external rotation, flex the knee and put on the opposite side of the knee, opposite side. So, you got my point?
Yes, sir.
Take the foot on the opposite side of the knee, abduct the hip, external rotate and press the knee down. It will open, the osteotomy will open.
Figure of 4.
One of the trick to open. Sometimes you need to use a towel creep or the distal fragment and then try and rotate. Sometimes that is very difficult because the bone is very thin and towel creep might pull out the bone. So this is one of the trick. Then put a graft and put 2 K wires. 1 K wire is not enough. Always put 2 K wires. These are small children. And then it is very important to use image. Sometimes these wires can penetrate into acetabulum and you develop a chondrolysis. So use image intensifier as far as possible, putting these 2 K wires. This is one of the example which my boss did way back in 1987. So this is the frog lateral X-ray. You see, this is the capital epiphysis, whatever is. It exactly, this is, if you draw a line, it directly goes to the triradiate cartilage. And look at this line is going above. Okay? That's why this hip is subluxated. So he did an open reduction. He did that. But look at this. One of the wire has penetrated. We don't know actually the oblique view, other thing, but we did take it out wire earlier after that. So you look at this here, there's a triangular wedge. Can you see, all of you? So
Yes,
the
yes.
triangular wedge here, and you look at the result of this child. The osteotomy is healed, the capital hip is coming inside, and after 2 to 3 years, look at that. The frog lateral X-ray, right, it is going into the triradiate cartilage. This is one of the wonderful operation for a containment Salter redirectional osteotomy. Clear?
Yes.
So this is the way it works. This is one more patient. Sometimes wherever there's an excessive anteversion, sometimes with Salter, you can do what is called derotation osteotomy, derotation. Somebody already had done this and it was dislocating, a very poorly done Salter. We don't know where it was done, poorly done. So what it was done was, we did a derotation osteotomy, corrected his coxa valga and brought it back down. Anybody knows this implant?
Smith-Peterson.
Smith-Peterson? Huh?
Smith-Peterson. Nail.
Yes, it is a pediatric. It is a pediatric SP pin and plate.
Yes, sir.
Who was the man who brought it in India? Dr. A.K. Talwalkar from Mumbai. Because I know it is very important, because one of the boy was almost getting a medal, but he didn't answer, so the boy was thrown out. So there are a couple of Indians who have a lot of contribution. You must know them by name. So A.K. Talwalkar, if you go to Mumbai exam, they will definitely ask you. Outside they may not, but just to tell you. This is a Talwalkar SP pin and plate, a pediatric SP pin and plate. This is 187. I was a registrar. I was a registrar. I was very enthusiastic. So I did this case in 87. Look at that. It is a subluxated hip here. Frog lateral going completely out. And this what I did at that time. I told you I was very enthusiastic. I put 3 wires coming from here and there, all that. 1 wire I had to take it out. This was 3 months post-surgery. And this is 1 year follow-up. And look at this 17 years follow-up of this lady. And that is a graph which I had taken out from that side, which is still not remolded. 17 years. I actually saw this lady in Mumbai when I was practicing just recently, about 4 years back. Unfortunately, I don't have X-ray. That is around 2012, 14 or something, which I don't have. But look at that. Still, this lady didn't require a total hip. She is going to need, if you see, some degree of joint space reduction is there. But this is 17 years follow-up on my own patient for a CDH. Okay, so Salter, you got it?
Yes, sir.
Yes, sir.
Okay, should be done from 18 months to 6 years, 10 to 15 OD correction. It is a redirection osteotomy. It only covers anterolateral part. It can be combined with open reduction, varicose rotation osteotomy. It is done at the level of the anterior inferior iliac spine. It is complete osteotomy. It has to be open, put a wedge, put a 2 K wires, look at the image intensifier. And important is the hinge is pubic symphysis, which is far away. That's why it is less versatile. Clear?
Yes, sir.
Yes,
Now
sir.
we go to Pemberton. This is a Pemberton Acetabuloplasty. This is not called osteotomy. It's called almost like a plasty, because I'll tell you why. It is a pericapsular osteotomy of the ilium. It can be done from 18 months to 10 years. It is on the slightly on the more age, because triradiate cartilage, if it is not fused, still allows to do it, because the triradiate cartilage is a hinge, and that's why if that is fused, you can't do it. This correction is more than 10 to, the Salter is only 10 to 15, but here acetabular index can be changed from more than 10 to 15 degrees of index. A small femoral head and large acetabulum is another indication. So it reduces the volume there. Very important. It is a small head, acetabulum is large. Now acetabulum is going to get compressed, going to the smaller configuration. So the head will be contained. It will not allow the head to subluxate. Got it?
Yes, sir.
So superior to anterior, again, this osteotomy level is again the same like Salter, that is superior to anterior inferior iliac spine. Okay. And triradiate cartilage is a hinge. Okay. And rotation is almost same like Salter. It is anterolateral. But here the volume is changed. Salter, volume is not changed. It is more versatile but technically demanding, because you have, if you break the triradiate cartilage, you will develop what is called chondrolysis. And normally it does not need any wires or anything, because it's too low osteotomy. Greater degree of correction, but less rotation. Alters the configuration I told you, capacity changes, acetabulum becomes smaller, because a large volume acetabulum into a small acetabulum now, small head. So if you do the premature closure of triradiate cartilage is likely to happen in these patients. So this is one example. If you look at this is a 3-year boy, look at the opposite side and look at this side. Look at the wide teardrop. It is subluxating. Medial joint space is much more. And look at this after the osteotomy. This couple of years, and look at this teardrop. Both sides is almost equal teardrop, and look at the thickness of the sursil on both the side, and this is Pemberton osteotomy. So Pemberton, now you got it.
Yes, sir.
Pericapsular, more versatile, volume changes, and it is does not require much wires or fixation. So we go to the next osteotomy, is the Sutherland double osteotomy. Now we were talking all the time single osteotomy. Now we are going to go double and triple and something like that. So Sutherland described double osteotomy in 1977. So iliac osteotomy remained the same, like a Salter, no change. Fixation, everything is same, approach is same. But now we are going to divide the anterior and inferior pubic rami just lateral to the symphysis, 2 centimeter lateral to the symphysis. So we are making that fragment almost like a separate fragment now of the acetabulum. Acetabulum can be medialized up to 1 centimeter by removing of the pubic. So we try and remove a bit of segment of pubis and ischial part, and then we can medialize them. So advantage of Sutherland, inferior acetabular fragments can be rotated in older children more than 6 years or 8 to 10 years. Medializes reduces the, which I told you, the body lever arm, stress on the hip. So 1 centimeter maximum you can medialize the acetabular, you can't then more than do. So fragment you can rotate well because you have got a double osteotomy now. It requires internal fixation for pubis because you are going to take out the segment. So you will require a fixation on the pubis also, you require it on the Salter side also. Axis of rotation of the inferior fragment is rather distant from the major site. So again, the hinge is not very close like a Pemberton. Hinge is still on the longer side. Cosmetic problem in females because you are taking out the pubic symphysis part, it becomes a little ugly looking because the segment becomes a problematic. So that's why the people are slightly worried of doing this osteotomy there. Correction is less than Pemberton, I told you, because you are away from the correction. That's why people started doing, instead of double, people started doing a triple osteotomy. So this is double osteotomy, Sutherland. Salter is this, and we take out the segment from near symphysis 1 centimeter, and that's why it becomes a little ugly here, especially in the female. They don't tolerate this osteotomy. So this is one example of a double osteotomy. Look at this, hip is subluxating out. So, and now after 2 years of this, so if you look at here, can you see here osteotomy and the symphysis level, and the Salter is completely healed. This is Salter, and this is osteotomy of the pubic symphysis, pubis. So that is double osteotomy. So we go to triple osteotomy now, and that is called Staheli, triple osteotomy. This he described in 73, that was in 77 somewhere. So we Salter remained the same, but the now separate osteotomy, both ischium and pubis both. But we are going now closer to the alignment of the acetabulum. So closer, not on the symphysis side. So we'll come closer so that the whole fragment can be rotated wherever you want in direction. That is easier to do. So greater freedom, no age limit, you can do it in older children also. Can be in paralytic. Paralytic is very versatile in paralytic because wherever the hip is dislocating, you can put that fragment there and put some fixation. So it is very versatile. Staheli is very versatile. Sutherland is not versatile. So disadvantage, unstable, that's what I told you. It's a difficult surgery and do require removal of wire. That is a normal phenomenon in these patients. So look at that. That is the Salter. So we are now going closer to the acetabulum. This is a pubic. This is the ischium. Sutherland did it far away. Far away from here. So this is still was very closer toward the acetabulum. Sorry.
मैं खाया बहुत सारा पराठा बना रहा हूँ बस थोड़ा राइस है बहुत सारा हाँ.
Okay, this is one patient of triple osteotomy. It was high dislocated, and you look at that. This osteotomy here, this osteotomy here is completely is a 4-year follow-up. Look at the hip, almost like a normal hip, except they do have certain degree of coxavara and a little bit of partly deformed type of little head, but they do work very well. And even they come at the age of 40 or 50, they totally becomes very easier. So this is an example of a triple osteotomy. So next was the dial. Dial and Eppright and Wagner, both are osteotomies are same, but one does with osteotome, and one does with something else, which I'll tell you. And Wagner, I was very lucky that I could see him 2-3 times. I could assist him also. And Wagner was a great surgeon who visited India, Bombay Hospital at least 3 to 4 times. And he was an extremely close friend of Dr. Dholakia. And these are few gentlemen who has helped our orthoplasty as well as orthopedics, quite a bit of orthopedics like Bombay, Wagner, Wellineger, Muller. All these people have helped to bring orthopedics in this country. So what is this osteotomy? A pericapsular osteotomy, 1 centimeter absolutely around the whole of the acetabulum, keeping his blood supply completely intact. This is a spherical osteotomy done by curved osteotome, and that is called Wagner. Same osteotomy is done by saw, and that was called Eppright. So there is no difference. Both have done the same osteotomy, but one with osteotome and other was with saw. So Wagner was slightly better because he could use the curved osteotomes all around. With a saw, it becomes sometimes difficult to do a curved osteotomy. So advantage, greater versatility. The whole fragment is a separate fragment now. You can redirect anywhere, wherever you want. This is also a stable osteotomy. Needs very simple internal fixation for this. The disadvantage is very demanding. Chance of chondrolysis. If you are very close to the cartilage, less than centimeter, then chance of chondrolysis are very, very high. So very highly technical demanding operation. We never did this osteotomy, to be frank. Even my boss did not do this osteotomy because it was very, very demanding osteotomy. But one of the example of dial which I picked up from the book, this is subluxating, a wide teardrop, and this is the follow-up of 6 years follow-up. And look at this is the osteotomy which goes all around like that. And look at the whole teardrop has become normal. And this is almost about 6 years follow-up of dial osteotomy done by Wagner. Now the new era came of this osteotomy. We still not a new era, what is said, but something new came, and that was Ganz. This was Ronald Ganz from Switzerland, Bern. A great work done by this gentleman. 2 important things he did for orthopedics. A lot of things, but 2 very important. One was this described osteotomy triplanar. Second, very important, is FAI. His complete baby is his. Nobody believed, whole world did not believe there is something like FAI, which are primary recurs of osteoarthritis. He took 30 years to convince the world there is something called condition FAI, and finally he succeeded before he retired. So this is the great gentleman who has the greatest contribution in orthopedics. So Ganz did a single approach, more correction, blood supply preserved, shape of the true acetabulum is unaltered, can be combined with trochanteric osteotomy if required. So what he did, it is a supra-acetabular oblique part of this oblique part. He did a higher than the Salter and all that. This anterior-inferior spine, he went slightly on the higher side. It's a cancellous, whole cancellous bone. The osteotomy goes all around from inside, all around from outside. So the whole fragment has become now almost like a separate. He put the spreader, put a Shan's pin, and you can mobilize this fragment wherever the direction you want. The whole fragment, which is supraacetabular osteotomy, whole fragment can be moved in the direction wherever you want. And only very important was, this is superior gluteal artery, all the blood supply is almost kept intact. So it is very, very dynamic osteotomy. And if you look at this picture, this was a retroacetabulum. Most of you know now what is called crossover sign. The anterior anterior lip and posterior lip, if they cross, that means it is a retroverted acetabulum. So he completely converted that into normal acetabulum anteversion. And that's a fixation you need that. At least about 2 or 3 screws are needed. So this osteotomy is totally versatile. You can remove the fragment in an elder child also. This can be done in a lot of dysplastic hips, a lot of this retroverted acetabulum. So it's a very, very important. Ganz osteotomy is very, very important. The Degas osteotomy is a pelvic osteotomy. It's an acetabuloplasty, again like a Pemberton acetabuloplasty, like a Pemberton, but slight difference. The primary indication is a presence of scapus acetabulum and posterolateral deficiency. We were talking on Pemberton anterolateral. This is posterolateral. That is the only major difference. And it can be done in often cerebral palsy because you are converting into posterior side, which Pemberton was not allowing, Salter was not allowing. But Degas will allow in cerebral palsy and polio, it will allow the posterior part, because the osteotomy hinge is not anterior, it is a more posterior. It's also used in persistent acetabulum in DDH, provides increased posterior lateral cover. Again, I'm telling you, osteotomy of lateral cortex of the ilium, and we do not keep the medial cortex. It is only lateral cortex of the ilium hinge, and the tri-radius again hinge like a Pemberton. Only the slight difference is between the Pemberton and this was this. The amount of inner cortex divided determines the fragment rotation. That is more posterior to sciatic notch hinge or medial cortex hinge. Open with a lamina spreader and put a tricortical graft. Even Pemberton we have to put a graft. Here also we need to put a graft, but no fixation. Is a stable because we are not cutting on the medial side, we are cutting only on the lateral side. Hinge is kept intact and the spica for 6 to 12 weeks. This is one of the example of a Degas. This is a dislocated hip. Can you see this dislocated hip? And you see this is after 3 years. That is osteotomy level. Okay, and that is the hip completely inside. A second example, very high dislocated. And look at this was 3 to 4 years follow-up, and complete remodeling of the osteotomy has taken place. So Degas is also a good versatile, can be used in cerebral palsy, can be used wherever the posterior subluxation is taken place, and hinge is much more different than the Pemberton. Now, shelf operation, that is called Staheli. We don't do much now. This is now just like a more of a theoretical. This can be done in adult. Increase the acetabulum volume, indicated in a deficient acetabulum, which cannot be salvaged with other procedure. That is the only indication. We still, some of the pediatric surgeons, they still do it because when there are no other facility, other surgeries are available. So this can be one of the proposition, but it does not give a good effect. Contraindication of self, dysplastic hip with spherical congruity where redirection osteotomy can be done. Hip requiring open reduction, it cannot be done. So what we do, this pericapsular, just above the capsule area, we just try to roughen the area and put some graft, corticocancellous graft, thinking that some amount of shelf will form. Pericapsular area will form. That is the reason this was done. But this gets fractured and normally does not take amount of weight that normally expected. So I don't think this is a very good operation. So we do in a very frustrated where there are no options. The next is a Chiari osteotomy. Anybody knows Chiari, how this operation was developed? I don't think, okay, but I should pass this knowledge to the younger generation because this was told by my chief. 1952, Chiari's boss was operating some form of osteotomy or something he was doing on the acetabular side, and Chiari was assisting him. And there were American surgeons who had come to see. This is Chiari, this was in Germany. So the Chiari was assisting, and some American surgeons have come to watch the operation. And superior gluteal artery ruptured. Patient started bleeding. So they had no choice. So what they did at that time, old time, we didn't have a cautery, we didn't have ligation, we didn't have nothing. And so the whole wound was packed with roller gauze and mops, thick pack. Go on pushing. And he was packed and he was closed, wound was closed with inside gauze pieces and all sorts of things. Hip spica was given. Patient was shifted to the room. And after 4 or 5 days, slowly, almost took 2 to 3 weeks to take out that gauze and the roller gauze. And at follow-up, this patient came and he had a medial displacement of the osteotomy because of the pushing of the gauze piece and everything. And at about 1 year, he had a very good result. A stable hip was created because of the medial displacement. So Chiari wanted to publish and do some operations. Till his boss was alive or he was head of the department, he did not allow Chiari to do this. Then in 1955, I think 55 or 56, he did a couple of operations, which I'll tell you, one of the long-term results of Chiari. So this was history. So it is a capsular interposition of osteotomy. We do not open the capsule. We do not open the hip joint. It is a pericapsular, very important. Osteotomy at the level of the superior margin of the capsule, all around, anterior to posterior, all throughout. So you expose in the front, expose in the behind, expose on the iliac inside side also. So all around it is opened up. And the capsule is identified with a strip by stripping with periosteum. So it is a medial displacement osteotomy. Superior portion of the osteotomy becomes the shelf operation. So some amount of fibrocartilage, some amount of the tissue develops there. And that gives a good shelf and not like a Staheli, because it is a good bone. Staheli, we are just putting a corticocancellous gauze, it will break, but here not. Congenital subluxation, even after over 10 years, 15 years, 20 years, Chiari can be done. Dysplastic hips with osteoarthritis, palatic dislocation can be done. Very coxopathies, where the head is subluxating out. This can be done and can be given some amount of shelf. This is a little contraindication. Complete dislocated can't be done, but people have done at the level of the higher part of the dislocation, which I'll tell you. So what the osteotomy was, if you look at that, that is the osteotomy. It's like an slightly oblique osteotomy. This is a capsule. Just leave the half a centimeter of the capsule above and identify by a radio marker X-ray, image intensifier, and you need to expose all around anterior, posterior, and the medial side. Most people sometimes do not do a medial side, but I did a couple of the cases, but I wanted to show that I'm protecting my osteotomy on the medial side, and it is very easy to do it. And also you are 100% sure that the whole osteotomy has been shifted on the side. So many people don't open the iliac inside part of it, but I did it. This is one of the greatest follow-up which I picked up. 66 patient, 80 hips osteotomy. Minimum follow-up. Shikunj-By, 27 years. From
Yes, sir.
27 to 48 years of follow-up.
Yes,
And only 40% patient went for a THR. 60% are still, the hip is alive at 26 years. And this is CCJR 2009. I think this is most likely a French literature. I'm not very sure, but this is something French literature. He learned the osteotomy from Chiari. This was one case my chief did. This was a little dislocated on the higher side. If you look at that, so the hip, the actually teardrop is here. But we have, at that time, we didn't had any choice of doing any osteotomies way back about 30, 40 years back. Salter cannot be done all over. So it was something like salvage he did. So it was actually true acetabulum here, but he did osteotomy at the higher level. And some form, look at the shelf created. And this is a 10 years follow. I actually don't actually, it's a 30 years follow of this child has come. And still he didn't require a total hip. So something self-operation, pericapsular, one of the example. So second example was, this was a patient actually from my hometown. This was a young girl came to boss and he did a osteotomy at the shelf here. Instead of here osteotomy, it was on the higher side. And this girl, recently, 2008 or 9, I did it totally for her. So almost 30 years, she was able to walk beautifully because there was the whole shelf was created like a acetabulum. So this was a great operation he did at that time. And because I wanted to do totally, I wanted to know what is a true acetabulum. If you look at the true acetabulum was here. So it was very, very small true acetabulum. So at that time, we whether wanted to do get the smaller bantam hip or something for this patient. At that time, there was not available. 2008, I think I did this girl. So I did a CT scan. I saw that it was a very, very small configuration of the acetabulum. This was a true acetabulum. So what I did, I brought to the normal center of rotation. This was overflow the acetabulum. Whatever the patient had head, femoral head, I just put that into that false acetabulum and put some couple of screws. And this is the follow-up of that lady, couple of years. She still has a limp. There's no question. This is not a normal question. And I had to do a subtrochanteric shortening because of the high dislocated, and that's osteotomy which is healed up. And rotation I was able to correct because with the S-ROM, that is a modular hip. So this is the way has been done. Now, the new literature has come. Post-osteotomy, after 20 to 30 years, the THR, now results are coming up, but numbers are very, very small. But it is easier to do because the acetabulum is well formed. There are no major complications after post-osteotomy of the acetabular site. So basically, if you're going through again, just to summarize it, that is your Salter, anterior inferior iliac spine. Sutherland, we add one more osteotomy at the pubis 1 centimeter away from the symphysis. The next osteotomy is a steel, that is a double osteotomy after Sutherland, double osteotomy, symphysis as a pubis as well as ischium, but we are coming closer to the acetabulum. Salter has been extra added here, so it is a triple osteotomy. Then lens osteotomy, I really do not know. Pemberton osteotomy where triad cartilage is a hinge. Dega, I told you, instead of going that, it is on the slightly on the higher side Dega, where you cover posterior lateral part rather than anterior lateral part. Hinge is slightly different. This hinge is anterior, that hinge is posterior. Ganz osteotomy, I just told you, is supra-acetabular all around, keeping a blood supply of the whole fragment and rotating the whole fragment wherever you want. It's a totally versatile Ganz. Then Chiari is the medial displacement, pericapsular osteotomy. Medial displacement can be done in older children. A shelf operation, but it is a salvage operation. It will require a total leave after some time. And last is shelf operation, which Staheli operation, which I told you. It's a salvage operation. It is a pericapsular, putting a corticocancellous graft on the superior part of the acetabulum, trying to think that it will form a shelf, but it's not a very good operation. So these are the osteotomies around the acetabulum. Are you okay?
Yes, sir.
Yes, sir.
Whether we go ahead or we stop here?
Whatever you like, sir.
Huh? No, because this is again a big topic. We can cover tomorrow.
So we can keep it tomorrow, sir. Tomorrow. Fine.
The next part is there are almost about 10 to 20 osteotomies more, and you can't grasp all of you. Srikunj is all right, but all other may not be able to grasp so many osteotomies.
Yes.
So we close here at that. Okay.
Sure, sir.
Okay.
Sure. We'll meet tomorrow. And thank you, sir. Thank you very much.
Thank
Good
you.
night, sir.
Thank you, sir.
Everything is clear. It was clear.
Yes,
It was very fine, sir. Very fine.
Okay. Okay.
Okay.
yes.
Okay.
We'll leave
Okay.
the-
Thank you, sir. Thank you.
Okay.
Thank you.
Okay, thank you, sir.
Where is the leave the meeting?